Are we good to go? Yeah, Tamara?
Yes.
Okay. Yeah, okay, brilliant. So hello to everyone. This is our Glycan Age educational webinar series. Zori is on her voice rest, so she asked me to step in and introduce Tamara to you. So Tamara is a colleague of mine. She's a senior researcher at Ghana's Glycan Science Lab. She graduated as a Master of Pharmacy at the Faculty of Pharmacy and Biochemistry, and she obtained her PhD in biochemistry at the Faculty of Science at the University of Zagreb. Her working experience includes public health and academia. Her research is currently mainly focused on monitoring significant aberrations of glycosylation in different diabetes subtypes, as well as possible utilization of marked changes as biomarkers and prediction tools. So Tamara, please start when you are ready.
Thank you, Lucia, for this kind introduction, and very good afternoon to everybody, and welcome to our webinar, where we will attempt to show you a brief overview of the research we've been conducting for the past several years now in collaboration with our partners, which involves the investigation about the role of glycans and their alterations in type 2 diabetes. Okay, so type 2 diabetes is nowadays, we can really say, the most common metabolic and endocrine disease. And it's actually characterized by the elevated levels of the blood glucose. As you are all aware of, glucose is one of the primary energy sources in our body and is absorbed from the food in digestive system. And multiple molecules are involved in its regulation and the regulation of its levels across the body. But perhaps the most important one would be this hormone insulin, which is produced and secreted by the beta cells in our pancreas. And what actually happens in the course of type 2 diabetes development are two major scenarios. So scenario number one, is everything okay? Okay. Scenario number one is that our blood glucose rises due to insulin resistance. So insulin acts on our targeting tissue, such as adipose tissue or skeletal muscle tissue. And in the course of type 2 diabetes development, this tissue becomes resistant to its actions. Another scenario, insulin production is not sufficient or its secretion is not sufficient, and then it cannot act as properly as it should, and as a consequence, blood glucose levels rise. And this, of course, is a hallmark of type 2 diabetes. So type 2 diabetes nowadays represents a global challenge and is spiraling out of control, and it's almost reaching epidemic proportions. According to the International Diabetes Federation, numbers for the year 2021 are not very optimistic, and it is estimated that 1 out of 10 adults is living with diabetes, and half of these people are still unaware of their diagnosis. Also, diabetes is one of the leading causes of death worldwide, and healthcare expenditures related to its treatment and treatment of its complications are also immense. But perhaps what is maybe the most important angle here is the fact that another 500 million adults have impaired glucose tolerance, which is a state of high risk of type 2 diabetes development. But still, at this stage, people can take actions, and if they act accordingly, they can delay or even totally prevent the disease onset. We can say also that type 2 diabetes is, in a way, a lifestyle disease. Of course, it has its genetic component, and you would have an increased risk for its development if you have a family history of diabetes. But all other risk factors are predominantly stemming from your lifestyle. So if you're obese or overweight, if you have if you lead inactive sedentary lifestyle, if you have inadequate diet, if you have high blood pressure, elevated blood cholesterol, etc., you have a higher risk for developing type 2 diabetes. And why is it dangerous? So maybe it would seem like prosaic to have high levels of glucose in your circulation, but during the course of disease and during the years, this elevated blood glucose is causing some serious damage to the blood vessels, and it's leading to the development of micro and macrovascular complications of diabetes, which can be like divided into two major subgroups. So macrovascular are mainly affecting your cardiovascular system and lead to brain stroke or myocardial infarction and other cardiovascular diseases. And microvascular complications predominantly affect your kidneys, your nerves, and your retina. What can you do to prevent diabetes? So you can take actions such as leading an active lifestyle. So you don't have to exercise vigorously, but in moderation. And it is estimated that if you exercise in moderation approximately 150 minutes per week, so this would be 5 times per week, 30 minutes a day, you would lower your risk by 25 to 35%. Then you should eat light and balanced meals, and this means eating fresh as much as possible and prioritize foods such as vegetables, fruits, fish, dairy products, etc. And of course, to avoid high-fat meals and high-sugar meals. Also, you should keep your waist circumference low. The lower the waist circumference, the lower the risk for developing type 2 diabetes and cardiovascular diseases. And the same goes for your blood pressure, which can be managed by decreasing the intake of the sodium and increasing the intake of the potassium, and of course limiting your alcohol intake. And you should also keep your cholesterol low. And now I would like to turn the story to the glycosylation, which we are focusing on today. And firstly, I would like to represent the difference between glycation and glycosylation, which gets mistaken for glycation a lot. And especially now in these terms of diabetes story, since glycated hemoglobin is one of the major markers for type 2 diabetes and diabetes in general diagnostics. And glycation is actually a random process. It is not regulated. It is not enzymatically mediated. And it actually denotes a covalent binding of small sugars such as glucose, fructose, or galactose to the proteins, which damages their function and stability. On contrary, glycosylation is a highly and strictly regulated process, is enzyme-mediated process, and it denotes the attachment of complex sugar molecules, which consists of several monosaccharides. It occurs within the cell, in the endoplasmic reticulum and in the Golgi apparatus, and it actually complements the protein structure, protein stability, and protein function, and it modulates protein function. So opposed to glycation, which actually ruins protein function, glycosylation complements and enriches the protein function. And why we also like glycans is the following, because glycosylation has no direct genetic template. So opposed to proteins which are encoded in our DNA, glycans are not. And glycans integrate genetic information with epigenetic and environmental influences. And since they integrate these three-way of information, they're highly sensitive to the changes in our body. And this is why they are good markers for prognostic purposes and for stratification of diseases. But these changes are not so specific for the disease we would like to investigate. And this is why they're not so widely used, because several diseases share similar glycan changes. And in the next couple of slides, I would like to introduce you to the effector roles of glycan in diabetes. And here, do you see my pointer?
Yes, we do.
Okay, thank you.
Yes, we can.
So I would like to tell you that glycans regulate glucose sensing, glucose cellular uptake, insulin secretion, and sensitivity across our body, and are majorly affecting the glucose levels in our body. And in the first line, they affect the glucose sensing in the beta cells of the pancreas. Those are the cells that are secreting insulin, so the major hormone which regulates glucose levels. So the predominant glucose transporter in the pancreas is this glucose 2 transporter. And it's a protein which carries a single glycan chain on its extracellular domain. Well, this glycan has to have a specific structure, so it has to be a high-branched glycan. It has to have at least 3 antennas. And only as such, it can be recognized by this galactin-9, another protein, which then forms a lattice with the glucose transporter 2. Why is this important? So this is important because only in such manner the glucose transporter 2 can be expressed on the cell surface, and by that enable the entry of the glucose into the cell. When the glucose enters the cell, it activates all kinds of downstream processes in which beta cells actually sense the levels of the glucose in our body and act accordingly. In other words, they secrete more or less insulin. And if the glucose transporter 2 doesn't have this proper glycan structure, so if it's a low-branched glycan, or if it's absent completely, it would not be expressed on the cell surface. There would be no glucose uptake into the beta cells and no glucose-stimulated insulin secretion, which would, of course, then eventually lead to the development of type 2 diabetes. And also, in the next step, once the insulin is secreted from the beta cells, enters the circulation, it has to cross the endothelial wall to reach the targeting tissue. And in this, I've selected a skeletal muscle cell as a representation of the targeting tissue. And then it binds to its receptor on the targeting tissue, which also activates all kinds of downstream processes within those cells, but which eventually lead to the cell surface residency of another glucose transporter. So this is insulin responsive glucose 4 transporter. And this transporter is enabling the entry of the glucose into the targeting cell. So this transporter also has a single N glycan. And this glycan doesn't have to have a particular structure, but what is important here, it has to be present because it's also enabling the translocation from within the cell onto the cell surface. If this glycan is missing, you would have no such translocation of the transporter, and of course, you would have no glucose entry into the cell, and you would develop insulin resistance. And thirdly, glycans play a critical role in the induction of obesity-related insulin resistance. So, obesity is a state of chronic low-grade inflammation, and in such a microenvironment, our immunoglobulin G, so our major antibody in blood, is in non-sialylated state. So it's lacking these terminal sialic acids, which confer anti-inflammatory properties. So as such, hyposialylated IgG is binding with more affinity to its Fc gamma 2b receptor. This receptor is present on the endothelium, and upon its activation, it's actually and in some way impairing this process of insulin transcytosis. So this is the process in which insulin crosses the endothelial wall. So it crosses our blood vessel to reach the targeting tissue. So if you have impairment in this process, you would have no delivery of the insulin to the targeting tissue, and you would have no glucose uptake into the targeting tissue. And then, of course, you would have elevation in the blood glucose levels, which would eventually result in type 2 diabetes. And here I wanted to show you that multiple studies have explored glycosylation and its alterations in multiple diabetes subtypes. And glycan alterations have been observed either on the whole plasma proteome or on individual glycoproteins in almost every diabetes subtype. Of course, the majority of research has been conducted on the two major forms, so type 1 and type 2 diabetes, but there has been studies on some rarer forms, such as monogenic diabetes, HNF1 alpha mode. And since I hope I've convinced you by now that the glycans do actually play important roles in the glucose homeostasis, I would like to introduce you to our analytical workflow. And I will not go into the details, but the studies I will be addressing in the next couple of slides have been done in one of these two ways. So we either looked at the whole plasma protein glycom. So you would take a venous blood sample which contains plasma, and we looked at the total plasma glycoprotein, and in a way that we deglycosylate the plasma glycoproteins, and we get this fraction of glycans, and then we purify them, label them, and analyze them by the means of liquid chromatography. Or we would fish out the IgG, so the antibody from the plasma proteins, and then deglycosylate the IgG, and the procedure is the same as it is for the plasma glycom. So we would purify the glycans, label them, and then analyze them through liquid chromatography or through the capillary electrophoresis, and then process the data accordingly and perform statistical analysis. So our first encounter with the glycosylation research regarding type 2 diabetes was within this study of hyperglycemia and critical illness. So our collaborators from the clinics at the time were testing this hypothesis that people who developed hyperglycemia during a critical illness actually already have some kind of latent disorder in the glucose metabolism, or in other words, those people have a higher relative risk for developing type 2 diabetes in the near future when compared to the people who would remain normal glycemic during such an acute critical event. And they recruited around 50 patients which remained normal glycemic during critical illness, and around 50 which developed hyperglycemia. And all of these people were discharged from the hospital healthy at the time, and they were sampled 6 to 8 weeks post-hospital discharge. At the point of sampling, they were all healthy. The lack of any inflammatory process was confirmed, and we obtained those samples and performed plasma and glycom analysis. And then based on their plasma and glycans, we wanted to classify or separate those two groups of patients. And in this ROC curve analysis, and got almost a perfect curve, so with the area under the curve of 0.96. And we were surprised ourselves that the glycans are so successful in discriminating those two groups. And we went on and explored this a little bit further. And then we collected another 4 populations. And what we saw across these populations, so some of the study participants were also developing hyperglycemia during critical illness. Others were monitored longitudinally for the incident type 2 diabetes, and others were just divided according to the HbA1c status, so they were either at high risk or at low risk for developing type 2 diabetes. And what we saw here is the people that have a high risk for developing type 2 diabetes, or people who already have type 2 diabetes, show this common feature, which is the increased complexity of plasma glycans which is basically the increased antennarity or the branching of plasma and glycans, increase in the galactosylation levels of the plasma glycans, and increase in the sialylation levels. And opposed to that, they would have decreased levels of these simpler structures, which are less sialylated, less galactosylated, and less branched. And then in the next study, we wanted to check if glycans can serve as a marker of elevated cardiometabolic risk. And for this purpose, we profiled plasma and glycom in 3,600 baseline healthy participants of this EPIC POSM study. And during the follow-up, 743 people developed type 2 diabetes. And based solely on their plasma and glycan levels, we constructed this risk score for incident type 2 diabetes prediction. And it consisted only out of this 6 and glycan structure. And we went on and checked the predictive performance of this newly constructed score and saw that the score performs quite satisfactory. So its area under the ROC curve was of 0.83. And when the age was added to the model, the performance increased even more. And it was comparable to this commonly used German diabetes risk score. But when both scores were combined, the predictive performance rose even more. And this was suggestive that the glycans do carry additional clinically valuable information, which is not contained within the usually used clinical risk markers. And then we wanted to explore the longitudinal dynamics of the glycan changes. And for this purpose, we profiled plasma and glycom in about 500 longitudinally monitored individuals from Twins UK Biobank. And during the follow-up, 89 people developed either insulin resistance or type 2 diabetes. And first, we cross-sectionally compared the people who did develop the condition and those who didn't. And so the similar changes as we did before. So the complexity of the plasma glycan was increased. There were more structures which are more branched, highly sialylated and galactosylated were elevated, and those who were more simpler and low branched were had a lower abundance. And then we went on and checked how the plasma and glycan behaves longitudinally for the most informative glycan structures. And what we saw here was that the plasma and glycans, which are the most significantly changed in type 2 diabetes or in people who have high risk for type 2 diabetes, actually show this gradual trend of change as the diagnosis of type 2 diabetes approaches. Or in other words, you can just say that the plasma glycans show continuous deterioration towards type 2 diabetes diagnosis. And in the same time, we were also monitoring the IGG Glycom in type 2 diabetes, and saw that the certain IgG and glycan features are changed in type 2 diabetes, and these changes were also replicated in additional 3 cohorts. And also, we wanted to check if IgG and glycans can serve as a marker of incident type 2 diabetes risk. And for this purpose, we also profiled the same study participants from the EPIC POSM study, where 743 people developed type 2 diabetes during the follow-up. And based solely on their IgG and glycans, we constructed this IgG and glycan score, which consisted out of this 5 and glycan structure. And then we went on and checked its performance. And what we saw here is if you would take into account the every single clinically used risk marker for type 2 diabetes development. So this would be this last column, model 3. And in this column, we took into account like basically everything. So BMI, waist circumference, smoking status, the level of physical activity, the nutritional habits, CRP levels, HbA1c levels, cholesterol levels, triglyceride levels, so basically everything. And the newly constructed IGG and glycan score still remains significantly associated with the incident type 2 diabetes risk. So this definitely proved that the N-glycans do carry this additional valuable clinical information, which is not contained within the traditionally used clinical risk factors. And to validate our findings even further, we performed the same analysis in 3 additional populations, which contributed with another 102 type 2 diabetes cases. And what we saw here, that the associations remain consistent across all studies for the majority of these individual N-glycan peaks originating from IgG. But what is the most important for this newly constructed type 2 diabetes IgG-based risk score? And lastly, what we've been dealing with this the last couple of years now is the question whether these unfavorable glycan changes may be reversed by beneficial lifestyle interventions. And what we've seen so far is this, that those structures which are the most informative and most predictive ones for type 2 diabetes development and even certain features of cardiovascular diseases, they have an opposite direction of change following beneficial lifestyle interventions such as low-calorie diet, so caloric restriction, and weight loss. So our first findings imply that the clock can be reversed, but of course we would have to still investigate this further to confirm to which extent and is this clinically relevant. And with this, I would like to thank you for your attention and invite you to freely ask questions if you have any.
Thank you, Tamara. That was very nice.
Thank you.
If anyone has any questions, feel free to just unmute yourself and ask. Or if you have any cases you would like to discuss, anything that might be interesting and related to the topic, feel free to join us. No questions?
You said at the beginning, Tamara, that you saw high blood pressure as a risk factor, as a causal association with altered glycan structures. Now, my prior understanding would be that high blood pressure would be a feature of metabolic syndrome, and that would be a secondary feature rather than a primary causal factor.
I'm not sure we understood each other well, because I listed the high blood pressure as a risk factor, like clinically validated risk factor for type 2 diabetes development. But we do see, if this is your question, we do see associations of the glycosylation with hypertension. And this is why we have to account for the hypertension when we do our modeling.
Sure.
But I'm not claiming it's a causative relation. I'm just saying these two things are somehow interconnected through the glycosylation. And this is why we have to account that for. If this answers your question, I don't know.
That does. Thank you so much.
Yeah.
We have a question in the chat. I don't know if you can see it. How precise is mass spec-based glycan identification? I imagine mass spec provides class of monosaccharides and the big picture of oligosaccharides structures, how reliable it is.
Yes, let me just. We also do mass spec, and those chromatograms I have shown you briefly are mass spec validated. So structures within the peaks are mass spec validated. But in our experience, the relative quantification we are performing here is more precise and accurate than the mass spec based one. I'm not saying the mass spec is bad, it's also good, but the chromatography is more robust and reproducible, and this is why we're based. And of course, it's a simpler way to quantify glycan structure. But of course, it has to be in conjunction with the mass spectrometry in order to get a validation and confirmation of your structure, which you're quantifying. Okay.
Can I ask a question as well, Tamara? It's so in regards to glycan age specifically, when you get a client who is diabetic, but they're controlling their diabetes well with medications, would you still expect their glycan age to be raised? So would that be reflective of their condition if they're medicated and that is medicated well, or on the other hand, if you have a patient who has a poor blood sugar regulation?
So I'm not sure about the glycan age. I can tell you about the plasma protein because most of the research was done on the plasma glycans. Those changes, I mean, as you approach the diagnosis, you reach a certain levels of these changes, and this afterwards is not changing so much. So regardless of so for example, we've conducted a study of glycans in diabetes complications. So this would be a feature of poorly regulated diabetes. And we saw no differences in the plasma glycans. So once you reach this certain threshold, so it's like the changes reach some kind of plateau, if that makes sense. Yeah. But what we did see was this reversal before you get disease, of course. If you do these beneficial interventions, then you would somehow tone down your unfavorable changes.
Okay, thank you.
There is another question in the chat.
Yes, I see. Does glycan age give us a longer lead time in predicting development of type 2 diabetes over standard tests? So I would repeat myself again. Glycan age is based on the glycoprofiling from immunoglobulin G, so antibody. And here the most research was conducted on the total plasma glycoprotein or glycans. And because the glycans which are contained within the plasma proteins are more informative than the IgG alone, because you have this acute phase reactants and you have lipoproteins, etc. And these are all contributors to the diabetes development. And this is why this kind of glycom is more predictive for the type 2 diabetes. So I would not know the answer exactly to this question. Another question, so besides caloric reduction, what are other factors which can help revert the clock? So, so far we've only investigated these two, so weight loss and caloric restrictions. We have done some studies involving vigorous exercise regimes, and those actually did not help, but the effect was quite the opposite, because it turned out that the harder you work out and the more vigorously you work out, you become like more inflamed. and your glycans go in this unwanted direction. So even the exercise should be in some kind of moderation. But we've just opened this topic, and we just started to explore this reverting of the clock theme.
There is another question in the chat.
I don't see that.
Or did I miss that one? Besides calorie reduction, did you reply to that one?
Can you, Zora, please read it to me because I don't see it.
You might have already responded to that one. Besides calorie reduction, what are the other factors which can help revert the clock? I have
this is what I've been answering so far. I hope I answered the question.
Thank you.
Okay.
Any more questions? No, perhaps we can wrap today.
Okay.
If anyone on the call has questions with regards to becoming a partner, selling the test, just reach out to us. You can easily create an account via partners.glycanage.com as well, and book a consultation with us or book a call with us so we can help you on board and explain the science behind the product. Thank you, everyone, for attending.
Thank you.
Thank you.
Tomorrow as well.
Have a nice evening.
Thank you.
Thank you.
Bye-bye.